All right, let's get straight to it. For your board exams, you have to think of the pituitary as the absolute command center of the endocrine system. There are no shortcuts here. Mastering its logic is mission critical.
So picture this thing like a multi-floor corporate headquarters. It's constantly sending out these critical directives, right? It's firing off ACTH to the adrenals, TSH down to the thyroid, and of course, LH and FSH to the gonads. Every single signal is a mission, and failure is not an option.
But, sometimes command just goes quack. That's what we call secondary failure. The brain's command signal drops, which means the target gland's output is going to drop too. It's a really simple, logical chain of command failure, starting from the very top.
But what happens when the commander doesn't go quiet? What if it goes rogue? Well, that's Cushing disease. The pituitary isn't being quiet, it's screaming. It's pumping out way too much ACTH, just causing total chaos down the line. See the difference? It's not a failure to communicate, it's a hostile takeover.
And this right here, this brings us to the ultimate board exam trap. Your labs are practically shouting Cushing's. You've got high cortisol, high ACTH. All the biochemical evidence is pointing a giant glowing arrow right at the pituitary. But then you get the high-res MRI back, and it's negative, clean, nothing there. So now what do you do?
Okay, this is a critical decision point on your exam. You absolutely cannot proceed to surgery just based on a negative scan. The mandatory next best step is Inferior Petrosal Sinus Sampling, or IPSS. It is the only way to prove definitively that the ACTH is coming from the brain and not from some hidden ectopic tumor hiding out in the lung or somewhere else.
And just a quick but very important disclaimer. This content is designed purely for educational purposes for international medical exams. It is not, in any way, medical advice. Always consult official guidelines and a specialist for any clinical decisions.
All right, let's really get into the weeds here with the core diagnostic problem, figuring out where the breakdown is happening. Is it the commander up in the brain, or is it the soldier out in the field? This whole concept is what we call diagnosing the level of the lesion.
So take a look at this. We've got two patients, patient A and patient B. Now they both have low free T4. No question, they're both hypothyroid. But look closer. Patient A has a TSH of 50, while patient B's is only 0.5. These look similar on the surface, but they are fundamentally different problems. Can you see why?
This is what level of the lesion is all about. In patient A, the soldier, the thyroid gland itself, has failed. So the pituitary commander is just screaming at it with a sky-high TSH of 50, trying desperately to get a response. But patient B? That's a commander problem. The TSH is low, even though the T4 is also low. The command center isn't even trying to send the signal.
So here's the absolute golden rule you have to remember. If you see a low pairing, that's a low target hormone like T4 and a low stimulating hormone like TSH, the enemy is not in the neck. The enemy is in the sella turcica, that little bony saddle that holds the pituitary. The problem is central, period. Okay, now we're entering what I consider the most dangerous territory on board exams, the negative MRI trap. Let's break down exactly why a perfectly normal-looking scan can be your absolute worst enemy.
So let's hit that critical question again. All the blood work points to a pituitary adenoma causing Cushing's disease, but that expensive high-res MRI comes back clean. How is that possible? Well, it's because these adenomas are often microscopic. We're talking less than 6 millimeters. They're just too small for even our best scans to pick up. And you have to remember, the absence of evidence on an MRI is not evidence of absence.
And this right here is the system vulnerability for test takers. The single most common mistake is to see that negative brain scan and immediately pivot, thinking, oh, the ACTH must be from an ectopic source, like a lung tumor. That is an automatic fail. You cannot abandon the pituitary as your prime suspect without definitive proof.
So how do we get that definitive proof? We bring in a specialized tool, a kind of localization shunt called IPSS. This procedure is the absolute master key to getting undeniable intelligence directly from the source. The logic is actually brilliant and super simple. An interventional radiologist threads a catheter into the inferior petrosal sinuses. These are the veins that act like the drainage pipes for the pituitary gland. We take a blood sample right there, at the source. Then we take another sample from a regular peripheral vein, say in the arm. And the final step? We just compare the ACTH concentration in those two samples.
And would you look at that?
The result is usually this massive gradient. The concentration of ACTH coming straight from the pituitary might be something like 400, while the level just circulating out in the arm is only 40. That huge step up proves, without a shadow of a doubt, that the pituitary is the factory that's pumping out all that excess hormone.
Now, this is the magic number you have to burn into your brain for the exam. The ratio. A ratio of ACTH from the petrosal sinus to the peripheral blood that's greater than 2 to 1. That confirms a pituitary source. It seals the diagnosis of Cushing disease even if you have a totally negative MRI.
Okay, time to put it all together. Let's run through the master matrix, rapid fire, to lock this axis logic deep into your memory. This is your go-to algorithm for the exam.
First query. You get labs back. You see a low target hormone and a low stimulating hormone. What is it?
That is secondary failure. The command center is down. Simple.
Next query. The labs are screaming Cushing's, but the brain MRI is totally clean. What is the next best step?
You perform IPSS. Do not pivot and start looking for an ectopic source yet.
Okay, so you did the IPSS, and you get a petrosal to peripheral ratio greater than 2. What does that tell you?
Logic confirmed. That is Cushing disease. The diagnosis is sealed. Now and only now can the patient proceed to the correct surgery.
So the anterior axes are secured. You've mastered the logic. But don't get comfortable because your mission is not over. If you can't navigate the tricky plumbing of the posterior pituitary or the absolutely lethal water wars of ADH, you are not ready. So the real question is, are you prepared for what comes next?